This instructional video presents a technique for arthroscopic reduction and internal fixation of displaced greater tuberosity fracture. The case demonstrates a knotless linked double row construct that uses anchors and suture tape. The injury occurred in a 47-year-old right-hand dominant male who fell on the ice and sustained a right greater tuberosity fracture with minimal displacement. He was initially treated non-operatively. However, he continued to have pain and weakness, particularly with overhead activity. At 4 months following injury, repeat radiographs demonstrated non-union of the greater tuberosity with 6 mm of displacement. The patient elected to undergo arthroscopic reduction and fixation. From a standard posterior viewing portal, the Hills Sach lesion is visualized and debrided. Subacromial decompression, acromioplasty, and lysis of adhesions are performed utilizing an arthroscopic shaver and radiofrequency device. An anterolateral working portal is established. Attention is turned to the greater tuberosity fracture. The callus is removed using a curette and an arthroscopic shaver. Prior to fracture fixation, the torn supraspinatus tendon and attached fracture fragment are mobilized to ensure that they can be reduced anatomically. After an anatomic reduction is obtained, fracture reduction is confirmed with fluoroscopy. Given the size of the bone fragment and concerns about comminution, the fracture was repaired using a knotless linked double row construct with suture anchors and suture tapes. A punch is used to create a socket for the placement of a 4.75 mm suture anchor medial to the fracture at the level of the articular margin. With the assistance of an arthroscopic grasper, a suture shuttling device is used to pass the suture tapes from the medial row anchor through the rotator cuff tendon. The process is then repeated for a second medial row suture anchor. Intraoperative fluoroscopy in multiple planes is again used to confirm anatomic fracture reduction. The footprint is prepared for lateral row suture anchor insertion. At this point, one suture tape from each medial row anchor is loaded through the first lateral row anchor. The suture tapes can be tensioned prior to insertion of the anchor. The anchor is then advanced into the lateral part of the greater tuberosity for fixation. The process is repeated for the second lateral row suture anchor. This construct compresses the rotator cuff tear laterally into anatomic position while simultaneously reducing the displaced greater tuberosity fracture. The construct prevents overreduction, underreduction, and tilting of the fragment. At this point, the shoulder is taken through passive range of motion to confirm a stable, reduced fixation construct under both direct visualization and fluoroscopy. Immediately following surgery, the patient is placed in a sling with an abduction pillow. On postoperative day 10, the patient begins passive shoulder range of motion. Active shoulder range of motion is initiated 4 weeks postoperatively. Resisted elbow flexion begins at 6 weeks, and at 8 weeks, shoulder strengthening begins. This concludes the technique video for arthroscopic treatment of greater tuberosity avulsion fractures.